It's me, Ashish. I'm a chief at Miami, interested in neuro-oncology, and Dr. Ivan here.
Hi, how's it going? Dr. Ivan, one of the neurosurgeons, brain tumor specialists, and skull-based specialists here at the University of Miami, and I direct our research program for specifically for glioblastoma.
Great, welcome.
And Rick,
Rick Komotar, also one of the neurosurgeons here, work with Ashish and Mike. Look forward to working with Nitesh Patel pretty soon.
Yeah, Nitesh is joining us. He's a recent addition here at Tumor Talk. Jason can't be with us today, unfortunately, but Nitesh has been helping us out both from a tech standpoint on the back end, in addition with Flora Solomon, and then he's been joining us for some of the conversation. So he's heading down there soon, right?
Yeah, he's heading down in, what is it, 10
months?
8 months?
Counting. 8 months, 10 months, 9 months? I don't even know.
Look forward to it.
There's a hazing process, right?
I mean, at least 2 months of hazing.
Yeah. All right. Well, why don't we get started?
It looks like there's some audio issue on IG.
Yeah, IG is restarting right now. I'm just restarting it right now.
Oh, great.
Well, we can. I don't know what happened there. Just
Yeah,
we can just start though. So it's recording anyway.
Yeah. Our group in Miami, we've been interested in this idea of supra-maximal resection for a little bit. Kind of started with Dr. Komotar's practice, and it's been kind of a field that's been really being pushed, I think, at a lot of the major centers. And I think that it's a very interesting topic, especially for glioblastoma, ever since we kind of established these extensive resection thresholds. So, and it's our practice that for non-eloquent region GBMs to kind of move towards lobectomy and anatomical lobectomy or supra-maximal resection when possible. And we happen to notice that these patients tend to do much better than the ones that just were offered kind of, traditional gross total resection or what we call lesionectomy. We kind of wanted to highlight, some of that some of that history and what kind of led us to that. And I think if neurosurgeons who kind of have an interest in history, I kind of have a little bit of an interest in that. These in 1950s, these original descriptions of lobectomy for GBM were kind of introduced. A couple of people out of the University of Pennsylvania and in Barcelona kind of suggested, okay, well, if you have a tumor in the right frontal lobe, right temporal lobe, occipital lobe, you should definitely perform a lobectomy. Unfortunately, at those times, the outcomes were pretty poor. You can imagine no microscope, no MRI, nothing. And these patients, died. Look at the operative deaths here. We had, almost 50% operative deaths or something like that out of this series from Northwestern. This is in the 1950s, 1960s, doing lobectomies. And, when the invention of the microscope, the idea of lobectomy is kind of, thrown away. People, were able to bring in the microscope and operate, and outcomes were very similar between, the lobectomy groups and the, microscopic, surgical groups. So with no difference in survival, that kind of abandoned lobectomy at that point in time. I think it wasn't really until, these kind of landmark papers, everybody's kind of familiar with these papers, from the UCSF group, the MD Anderson group, extensive resection papers, and kind of moving towards maximal resection that, that we kind of thought about, looking back and saying, okay, well, maybe we should go back towards supra-maximal resection. And, the data, speaks for itself. The amount of papers they're suggesting extensive resection are going up and up every year. And the clear benefit in their overall survival is very clear. You see this from the 5-ALA trial to, these other papers by MD Anderson and Hugh Defoe. And I think the whole concept, was really based on this, the data, Pat Kelly, when they did these initial stereotactic biopsies of, GBMs, they noticed that, 2 centimeters away from the tumor, there were still microscopic tumor cells, infiltrating normal brain parenchyma. So, the idea is, why can't we just chase, that extra 2 centimeters? And anatomic lobectomy kind of allows us to do that. This is kind of one of those old school slides here. You can see the, infiltrating tumor cells kind of going in here. So, I don't have to rehash all this, but Hugh Defoe kind of described this idea mostly for low-grade gliomas, and this is kind of the idea of supramaximal resection for low grade. This is kind of the first idea that this was proposed like 10, 15 years ago. And then, kind of got expanded for, high grade gliomas, and, the MD Anderson group published in JNS, suggesting that, if you resect at least 56% of the flare abnormality around your GBM, then you can get even better overall survival. And you can see that here in this Kaplan-Meier. So we said, well, why don't we take it one step further? And a few groups demonstrated, that lobectomy, could really, improve overall survival even more than what we traditionally look at, gross oral resection. And this was a group out of Korea that kind of looked at that data. And, so since we had an extensive series of patients, we had, around 50 or 60 patients of non-eloquent GBMs, newly diagnosed and underwent lobectomy, we thought that maybe we could, look at these series and provide our insight. These other small series that were published were, 20 or 30 patients. So not many patients. And so we kind of thought that maybe we can look into this a little bit. And I think Rick can kind of talk a little bit about, kind of how he looks at patients and decides whether or not they go into lobectomy or not.
Oh, do you want me to talk about that now? Perfect. So you want me to talk about it now or when we get to the technical part?
Yeah, we can get to the technical part. Yeah, essentially, we kind of decided that, in order to look at this scientifically, I think that the main point is basically that we had to basically create two cohorts that are very, very equal, that either they're a lobectomy cohort and a gross oral resection cohort. And we wanted to eliminate all the types of biases. You can imagine that, comparing eloquent region tumors to non-eloquent region tumors would present a problem. If you compare left and right sided tumors, it's a problem. If the size of the lesion was different, that's a big problem. So, we wanted to control for all of these things. And so we kind of designed a study that we looked at our institution and patients who underwent non-eloquent region GBM surgery. Either they went under lesionectomy or lobectomy, and this is all determined, by two different independent radiologists. And then we looked at their outcomes. So all of the patients had to receive STU protocol. All of them had, relevant, KPS scores. All that stuff was all, IDH mutation, MGMT were all calculated, and we controlled for all of these things. And then we did something called propensity matched analysis. And this is kind of a fancy little statistical way to use a retrospective study and kind of almost look at it as in a prospective way. So basically this kind of controls for all these small little, changes. So we could try to control for KPS, tumor size, methylation status. So that propensity matched analysis kind of allows us to simulate a randomized control trial. So I think this was kind of the unique part of our paper, is this idea of propensity matching. And I think that, when we look in the future and look at retrospective studies, we should expect them to have some sort of propensity matching to control for, these kind of variables, because otherwise, you're not really getting a real control group. So we controlled for things we thought were important, their functional status, tumor size, location, age, of course, because we know older patients do worse, and the amount of flare signal. So, we controlled for all of these things. And then we did our inverse probability of treatment weighting to kind of get us some important data. I mean, this is kind of our baseline characteristics of our study. We had around 69 patients total, around 40 in the gross oral resection group and lobectomy, and 32 in the lobectomy group. I mean, we eliminated patients, who had multifocal GBM or things like that. So, or patients who had previous treatment. So, this is a very, very selected group of patients in a very niche study. So you can only have a right temporal lobectomy, right occipital, right frontal. So those are the kind of, those are the patients we included. And as you can see, there's not really any difference between IDH status, MGMT status between these two groups. KPS scores were comparable as well. So, I mean, here I'll defer to Rick a little bit about this, but this is kind of a nice little collage of our cases about who we, decided to go to frontal lobectomy versus, a gross oral resection. You can kind of just, you can see our decision making here.
Yeah, so I would say for the most part, our default is lobectomy. If there's a non-eloquent high-grade glioma, in temporal, frontal, occipital lobe. Occipital, obviously, they have to have a homonymous hemianopsia already, which most of them do. But if any of those situations arrive, then our default is lobectomy. We don't do a lobectomy if you could see here on the top left, if there's a tumor that's all the way back in the right frontal lobe, it just, for me at this point, it still seems hard to justify taking out the entire right frontal lobe when the tumor is all the way back near motor, and the entire frontal lobe kind of looks normal. Same thing with the temporal lobe. If the tumor is, like behind labe, it's posterior temporal, hard to justify taking out the entire anterior temporal lobe when the tumor is small and it's so posterior. But if any of those situations don't arise, then we do lobectomy. And the nice thing about lobectomy is that it's the same way every single time. So it doesn't matter if it's a small frontal tumor or if it's a large frontal tumor or a small temporal tumor or a large temporal tumor. It's the same incision and it's the exact same, anatomical landmarks every time, and you stop at the exact same place every single time. So it just becomes a lot easier when you do a bunch of these. It becomes very kind of cookbook. For the frontal lobectomies, we do a small linear incision. It goes basically from just above superior temporal line to just across midline, right at coronal suture. We do a craniotomy, again, relatively small, frontal. You work your way down at first. You kind of create space for yourself, find the floor, work your way back until you find sphenoid wing, which is kind of your safety margin looking back posteriorly. Anything further back posteriorly, then you run the risk of hitting the perforators and causing hemiplegia. So you find the wing, find the optic nerve, and then you bring that straight up kind of perpendicular, and that will help you avoid the frontal horn of the ventricle. Not the end of the world if you get into the ventricle, but it's just, these patients do better if you avoid the ventricle. They just come off decadron quicker. There's no pseudomeningocele. So you really want to try to avoid getting into the ventricle if you can. Medially, it goes all the way up to the falx. And then laterally on the right side, you want to go all the way out to the sylvian fissure. And then on the left side, you want to go out to the inferior frontal gyrus, which is where you obviously have language. That's the frontal lobectomy. Temporal lobectomy, back when I started, I was doing much larger incisions, which is kind of the classical teaching, doing a reverse question mark. As you get more comfortable with these, we've moved towards a much more minimally invasive approach. It's a linear incision. It goes from basically zygoma up to superior temporal line. Again, relatively small crani. And the same kind of principle applies. You want to start with the anterior temporal lobectomy, which is the safe part. Move forward, find the floor, and then really create space, because it's a very tight corridor when you do these minimally invasive approaches. You find the floor, disconnect those veins up at the front, up at the anterior temporal lobe, find the sylvian fissure, do a subpial dissection, expose the sylvian fissure, expose the insula, go back to about labe, I would say, is the general kind of posterior margin. And then you do the medial structures. You find the uncus first, and the amygdala, take that out, and then take out hippocampus moving back, typically until you have tectal plate. That's a complete temporal lobectomy. And then occipital lobe, prone, linear incision again, kind of going just below transverse sinus and up to about the occipital parietal sulcus. Again, relatively small crani, work down, make space for yourself, find the tentorium, find the falx, and then work back until you find incisura, and then that's where you stop. You're going to get almost assuredly into ventricle posteriorly. That's fine on the occipital lobectomy. It's really hard to avoid that. And then laterally also can be very tricky. Typically, the ventricle helps you determine what your lateral boundary is. So when you find the ventricle, if you look, that's a good image on the lower right corner. You see after the tumor's out, once you find ventricle, the lateral wall of the ventricle basically should be the lateral extent of your lobectomy. So you basically find the ventricle, find the ependema, and then you kind of draw a line straight out, and that's a formal occipital lobectomy. And then superiorly, you're always going to find parietal occipital sulcus. That's very, very clear. You're going to find major arteries, major vessels in that sulcus, and so that's where you stop superiorly. So those are the technical aspects for that.
Yeah, I think, and the interesting thing is, in our institutions, there are some of our surgeons that actually, do a supra-maximal resection, and some of them, do only lesionectomy. And so it was very nice to be able to conduct this study, and look at the, radiographic, outcomes between different surgeons, and looking at and try to control for all the different variables. So I think this was kind of a unique part.
Yeah. So, I mean, really, just to interrupt for a second, I mean, you guys are going to show the results now, obviously, but just to kind of summarize, it sounds like you really need a lesion at one of the poles, right? This is going to be your optimal lesion, either at the frontal pole, temporal pole, because you really want, I mean, the idea here is lobectomy, meaning supra-maximal resection to some degree, right? So you want to be able to get behind the lesion. So let's look at the results, but then I guess one of the questions would be, do you notice a difference if a lesion's kind of on the boundary of one of these areas? I know you said you won't do it if it's a smaller lesion, kind of, behind labe or near labe, or posterior frontal, but if it's still a large size extending to there, have you seen differences or looked at that, or is it just a volume issue?
I mean, I think Randy, the other thing that you're getting at is with this idea of why we're looking at the poles is because we want to minimize the side effects and the risk profile of these patients, right? And that's always the big question is people have always fight about, doing a supra-maximal resection because they're like, well, you're introducing this idea of risk, neurological deficits, cognitive deficits, and whatnot. And so we focused purely on the pole because we felt like the surrounding risks of taking additional brain were so low that we could basically almost negate that profile and really just focus on the question at hand, which is survival and progression-free disease survival, is there benefit with taking a larger margin? Since we know that in 80 to 90% of glioblastomas, they all recur within the first 2 centimeters of the surrounding margin, right? And so, yeah, I mean, that is an issue, but I think that's a huge part of why we designed the trial in this method.
Yeah, absolutely.
I also think just to comment kind of technically, a nice thing about lobectomy is when you get into that routine, it makes the surgery faster, it makes it quicker, and it makes it better. So if you're constantly, checking the margins, have I gotten all of the tumor? Is there going to be some enhancement left? And you're sitting there and you're under the microscope and you're going back and forth and navigation, first of all, I mean, that just takes longer. 2, you're definitely going to leave some tumor behind at some point. You're going to leave a little nugget of residual and you're going to be annoyed with that. If you do a lobectomy, it's loops and headlights. It's a quick case. It's the same boundaries every single time. There's no difference. And if it's in that lobe, then you're going to get a gross total resection, if not supra-maximal, every single time. So I think it's a larger surgery, but it's easier, it's faster, it's quicker, and it's better for the patient.
So yeah, show us the results. What are we looking at?
Mike, if you want to go over the results there.
Yeah, sure. So again, using propensity scoring, we basically just first compare the gross total resections versus lobectomy in our patients, and we looked at overall survival, progression-free survival, and you could see that there was a significant difference in benefits in both outcomes. Specifically, the overall survival, this comparing 30 months to 14 months. You could even say that maybe 14 months is a little bit low and that the average is somewhere between 14 and 18 and 19 months currently. But with a maximal, resection, you get up to 30 months in these patients, which is definitely better than any data that we've been seeing for any clinical trials or whatnot at this point in time. So I think that's a great outcome for them. And the complications, there was no significant difference. Again, this is a small cohort, right? I mean, this is kind of proof of principle in what to look at for. And so if we kind of break down these cohorts a little bit further into the mutational status, that was our other question, because we know that glioblastoma is extremely heterogeneous. And so there's a lot of different subtypes, a lot of different mutations. Propensity scoring captures some of that, but not all of it. But the two main cohorts are really MGMT positive and negative. We wanted to see if there was a difference in those, and then IDH1 positive and negative. Since the in IDH1 tumors, there's this hypothesis that the invasion is significantly different, and that the IDH1 positive tumors are much more well circumscribed. So perhaps getting an extreme resection is not quite as effective or not. However, the low grade data would support that it is. But in these cases, if you look at the top, we show here, I think the most interesting part is that in the wild type gliomas, which you could argue has the most spread and the most invasion of tumor, we still see a benefit in overall survival. So it'd be the red to the dark green, and you can see that the lobectomy with the dark green line is still significantly higher than the red. Now, the benefit for the MGMT positive is not as great, and that's expected because those tumors are much more susceptible to chemoradiation. And so I think that those tumors tend to respond better. IDH1 positive, we didn't have as much of those patients in the cohort, so it was really hard to compare the IDH1 mutated patients for GTR versus lobectomy. But again, if you take out the IDH1 mutated and just focus on the IDH1 wild type, again, you see that there's a significant benefit in lobectomy versus just gross total resection. So even in the worst case scenario, you're seeing benefit in these patients.
Yeah, I think that's incredible. And I think it really speaks to this idea of, reducing residual volume, right? I mean, you're reducing, whether it's IDH wild type or mutant, you're reducing the residual volume in this disease to cells, single cells that have migrated away fast past this border versus, what still might be there adjacent to your enhancement. So it makes a ton of sense. And I think great work.
Yeah, so I mean, and Ashish just highlights on the next slide, there are limitations. I mean, obviously, this isn't a multi-center blinded trial by any means. It's just our own internal trial. We have multiple surgeons, which again do multiple techniques, but I think all of our patients get very similar care post-operatively. We're all kind of get the normal standard stoop protocol, and they're all kind of under the same protocol with timing of treatment. So I don't really see that multiple surgeons as a limitation. I think that that's actually a huge advantage in this study. And then again, the question is okay, well, we know that the deficits and infection rates and post-op DVTs and UTIs, all the things you would look for complications are not different, but neuropsych testing is obviously missing in this study. And I think this was the proof of principle for us to kind of to prove to ourselves that there's significant clinical benefit for survival and progression-free survival. Now, can we go back and start doing like really extensive neuropsych testing to understand, okay, how do you draw the line for who is the best candidates for lobectomies, and do you take it beyond just frontal, temporal, and occipital? Do you start including parietal and other lobes that may be beneficial if their neuropsych testing allows that ability, and that they already have a deficit in that area, and therefore it's unlikely to improve with or worsen, or perhaps they have a large importance to their temporal lobe and memory and speech and language that you're not expecting, and therefore you wouldn't do a lobectomy. And all those questions need to be teased out very carefully.
So are you guys doing neuropsych testing on all these patients?
Yeah,
actively,
we're working on getting a large clinical trial going now, and we hope to get it enrolling by January 1st. That's going to be looking at just exactly this fact.
Yeah. So listen, you guys do go ahead.
Just gonna real quick. I just wanted to sort of look back to, we had our I think it was a couple of weeks back, we had a Dr. Q on who talked about sort of age of acquisition and language mapping, et cetera. And I was sort of surprised by that talk, and how language doesn't necessarily map to one area. I mean, people acquire language at different ages and stuff, and it could be sort of all over. So on that topic, do you guys employ DTI? Do you guys have any sort of fMRI or anything like that you guys incorporate, or something you guys looking forward to sort of having in future studies, along with the advanced neuropsych testing?
Yeah, so I would say no, we do not do that, just because these are non-eloquent lobes. Yeah. So we do not do fMRI or any DTI. But you are basically alluding to Hugh Defoe's principle of you go until there's functional, basically neurological deficit almost. And that's a great concept, and it would be great if you could do it. But I think the first thing to understand is that he has an unbelievable team and setup around him that I don't know of any other place, in the world that really has that setup around him. I mean, the guy's meeting for 2 to 3 hours with every single patient, going over it, and he has a neuropsychologist in the OR. And anyway, so we don't, because we just do lobectomy. But if you were going to push it to the functional extreme, then you should get functional MRIs, then you need neuropsych testing, and that's the next level. But I don't know of any place in the US that has the setup to do what Hugh Defoe does, which is pretty remarkable.
Yeah. The other thing you have to remember is that in these patients, Hugh Defoe's work is primarily in low grades, right? So he's meeting with these patients, and many people who do the low grades analysis, they meet with them several times. They get neuropsych testing, a battery for many hours, functional MRIs, and that workup takes almost a month or sometimes longer. These patients that present with glioblastoma, they're presenting with severe issues, that are acute, whether it's a seizure or a speech problem, and you need to make that decision typically within a day or two of what the next step is. And so we're trying to, like I said, in the next clinical trial that we have going, we're going to be kind of working on that time scale of being able to get the DTI connectome analysis done within 24 to 48 hours to kind of see if we could figure out the differences. But it's a different scale, because you're comparing, low grade tumors where somebody could be with a neurocognitive deficit for 10 to 15 years versus somebody who may have a small deficit, but you may be able to gain them, 30 to 40% more of their life.
Yeah, I think that's a very big difference. Discussions with him, he checks the rate of growth of these lesions over months. So he sits with these patients for a long period of time before he even operates on them. Whereas this, like you said, you have a couple weeks at most here. So when you guys are doing dominant hemisphere, when you're doing a left frontal lobectomy, you said you stop at the inferior frontal gyrus. Are you doing those awake, or are you doing them asleep? Because this is basically an anatomic resection.
I typically do it awake if I can. Then you can be a little bit even more aggressive and go past that sulcus. But a lot of times these patients already have an aphasia. You don't know what's kind of due to edema, what's due to tumor. So the safest thing to do, if you can't get a good exam, would be just go down to the inferior frontal sulcus in between middle and inferior gyri.
Yeah. And then the other thing is, based on what we know about, like you said before, parietal lobes and, posterior temporal lobes, do you think there is a role for supramaximal resection in those areas, given how, condensed function is in these areas, given the fact that we know that tumor spreads through edema, and in general, that's a very tight space, and you're already kind of infiltrated into the motor strip or into eloquent cortex somewhere. Do you think this is something kind of strictly limited to these regions, or do you think just more work needs to be done?
I mean, I think parietal lobe, my problem with the parietal lobe is just that the anatomical landmarks are not really clear. I mean, you got the falx medially, anteriorly, it's obviously sensory motor. It becomes a lot less obvious. And then posteriorly, I guess you could have parietal occipital sulcus. But, I think parietal lobe has so many critical functions that if you do a complete parietal lobectomy, even on the non-dominant side, that person's taken a pretty significant hit. So I think temporal, occipital, frontal, I feel like when I do large resections in that area, patients can still wake up great, go home the next day, feel good, go back to a high level job. When I do a large parietal resection, those people are stunned out pretty hard. Yeah. So I don't think parietal lobectomies are a good idea, because the function there is pretty dense, and those are pretty eloquent areas of the brain.
Yeah. Well, guys, I mean, we try to keep these to about a half hour. We're approaching our limit here. Any last words?
I mean, maybe this is something, that we can have Nitesh study when he's down here. I think this is an amazing, year-long project. If we get funding and Nitesh can run a clinical trial here, I think that would be amazing. So something to look forward to.
Absolutely. I'm happy to collaborate too. I mean, I subscribe to this stuff. I think that the evidence for supramaximal is phenomenal. And I think that it comes down to patient selection, which you guys have a really nice algorithm here that you've kind of laid out for us, both technically as well as patient specific, and how you choose who you're going to help this way. and the outcomes speak for themselves. So I think a bigger study, you know, supporting that would be great. And the neuropsych, I think, is absolutely necessary. You know, we're ultimately kind of in a service industry. We got to make sure people are functional afterwards. So great work. Thank you guys so much for coming on. It's always a pleasure. And we look forward to having you guys back again soon.
Thanks for having us, Randy.
Thanks, guys.
All right, Randy. Awesome. All right, Natasha, take care. See you guys
Thanks
later.
for supporting the JNL.
Take it easy,
Talk to
guys.
you later.
Always.
Take care, Ashish.
Take care.